and the friends from the states, district hospitals, PHCs, and tertiary care institutions, and the central government institutions, and those who are working in other organizations, whether defense, railways, or whoever is connected. So few of you must be connecting for first or second time. As I mentioned last time also, that this is the initiative which NHSRC and Delhi Society for Promotion of Rational Use of Drug started about 2.5 years back for improving the clinical practices, improving the adherence to the standard treatment guidelines, which is important for everyone, all of us who are working for the strengthening of the system, and also the other challenges which are coming up, like antimicrobial resistance and healthcare associated infections and other related issues. And this initiative has made a lot of impact. And the key driver behind this initiative has been, besides our ED, Major General Professor Atul Kotwal, who is not able to join because of other competing priorities. For some other event, the preparations are going on the best practices. And Professor Sangeeta Sharma. In fact, many of you would know her personally also, that she has written the books, have been contributing to the journals, conducting the training programs on all these three areas which I mentioned: adherence to the standard treatment guidelines, antimicrobial resistance, clinical pathways, and other things. The standard treatment guidelines are not only important for the primary healthcare setup, but they are equally important in our teaching institutions and apex institutions also, where the future generations of the doctors, nurses, they are being groomed to take over the responsibilities, so that the basic, they get into the practice of following these guidelines whenever they move away. And of course, they remain important for the primary healthcare setup, where hardly there is any scope for the clinical enhancement or the CHOs who are working in a real resource constraint setting. So without much, in fact, going into the background, today we have got the three topics and the agenda has already been shared. There is a bit of change because Professor Sangeeta Sharma will be covering first challenges with the management of the fever, and we all know her. Then next session would be management of fever in fact, in infants and young children, because we all know, and particularly those of you who have gone through the parenthood would feel that when something goes wrong with the child and the young, infant who is not able to convey much, express much, and that goes into the fever, and he or she is also prone to certain complications, whether the convulsions. And then we have another, this session will be conducted by Dr. Shobhna Gupta, who is Deputy Commissioner in charge, Child Health and RBSK. Then the next session is by Dr. Anup Warrior, who is a known figure for the management of the infectious diseases. So without much ado, I would request Professor Sangeeta Sharma to say a few introductory words and then kindly start the session. Thank you very much.
Thank you, Dr. Srivastava, for creating this platform for connecting with so many people across India from various levels of healthcare. We could not have imagined this kind of a participation, countrywide participation from all levels and from different cadres of healthcare. I think personally also, the day before yesterday when we had a conclave, many people approached us and they liked this series, and the feedback had been that this series is helping them in identifying the gaps in their clinical practice and addressing those. And these expert-led sessions have been really very helpful. Thank you to all of you for having appreciated this, and we continue hope that these things continue and you strive to improve clinical practices accordingly. Now, as Dr. Srivastava was mentioning, see, more than the access to healthcare, now there is enough evidence which says the quality of care is even more important. So far we had been worried about the quantities, but now quality, quantity is not equal to quality. Quantity with quality is equal to good quality care, and more number of deaths happen because of poor quality of care. So, access has been maybe a real concern even for some of the remote areas. Besides access, we need to see how and when, where we can improve this quality of these healthcare. So, with this thing in mind, sorry.
Ma'am, we are not able to hear you.
Just a minute.
Yes.
Can you see my screen?
Yes, ma'am, it's visible, but the content is loading.
Okay, it will take some time.
Yes, ma'am.
Okay, can you see this slide?
No, ma'am.
Uh, can you see now?
Yes, ma'am.
Okay, so let's look at what are the challenges in the management of fever in children. Now, there are three different, special challenges that we face, and this arises from their age. This may be a newborn, neonate, infant, small children, big children, and as Dr. Srivastava was mentioning, another significant challenge is that their inability to communicate effectively. What is it that they are suffering from? What is it making them sick? They cannot communicate their problems, and this, the fever may be just sign of other potential underlying conditions. So, age-related variability is there, and definition of age groups and fever also varies. Their immune system is still developing, making their responses to infections and fever less predictable than in adults. And you may not find a typical fever symptoms, which will make the diagnosis and management more challenging in this. So, there are three different, generally children, when we talk about their management, we divide them into three different categories: younger than 1 month, 1 to 3 months, and 3 to 36 months. Now, thresholds for fever. This is a very important concern. Wherever I had done the audits or I interact with the people, uh, most of the time in the pre-test also, we ask this question. Anything slightly above the body temperature is considered as fever. 98.6, I've seen many people popping up paracetamol for that they have fever, and equally the prescribers are also prescribing paracetamol even for a smallest, right? Please understand, the 98.4 temperature that we give is an average body temperature. For individuals, body temperature may be lower or higher, or we call it a fever only when it is more than 100.4 degree Fahrenheit, or in terms of centigrade it is 38. Below that is not considered as fever. So a lot of over treatment is seen. And also we must understand that the device that we use for measurement of temperature, their threshold also varies. So you should know this, what are the threshold for if you take the oral temperature, or if you take an axillary temperature, or temperature above 39 degrees centigrade usually needs antibiotics. Below that you can manage even without antibiotics. Hyperpyrexia we call it, because when it rises above 41.5 degree. So in children more than 3 months of age, rectal temperature less than 39 degrees need not be treated. So please understand these threshold. And as we asked this question, whether any fever management device can be used, there are several devices which are available in the market. Not all of them have equal accuracy. So you need to, the most accurate is the rectal temperature thermometer. But I know measuring rectal temperature is unpleasant, maybe inconvenient, but that's the most accurate one. The peripheral thermometers, tympanic membrane, temporal artery devices have become more common, but you have to understand their limitations. Now, then next challenge in the fever management is, how do you classify them? Usually they are classified as acute, subacute, and chronic. Acute is when it is less than 7 days, subacute is 7 to 28 days, chronic fever is more than 28 days. So when we describe patients with fever, we need to keep this duration in mind, because many a time some 7 days or less than 7 days may be considered as subacute chronic prolonged fever, and then the cascade of inappropriate diagnostic testing arises. Now, as I said earlier, communication barriers are there, and often young children are not able to communicate this, and this also makes difficult for the caregivers and healthcare providers to identify the cause of the fever and assess its severity. Now, one of the major concerns whenever the child has a fever very often is the febrile seizures, especially those who are prone to get this febrile seizures. Although it is not very these are seen between the ages of 6 months to 5 years, and usually these seizures are brief, lasting less than 5 minutes. In simple cases, they are not a sign of epilepsy or other serious condition, but many of us, the parents as well as the healthcare professionals, they panic about it and they label this. Usually these febrile seizures are seen because of a sudden spike in the fever, but if you take care of that, it is not necessary that a child who has had seizures in the past will have seizures during this current episode of fever also. So mostly are not harmful, so do not require immediate medical interventions because they last for less than 5 minutes. Yes, we need to know when to tell the parents when to come back, seek medical attention immediately. Whenever the seizures last longer than 5 minutes, the child has difficulty breathing, or there is a repeat seizures happening, the child appears extremely ill or has a trouble waking up after the seizures, or if it is a first febrile seizures, yes, you need to seek medical attention. The the most important part of the management at this time is that we need to protect the child from any injury, because in during seizures the child may fall or has some injury. Excuse me, जरा थोड़ा noise कम करोगे? Yeah. and don't put anything in the mouth during seizures. The patient must lie on the left side. We must protect the airway for this child. So now, frequently, most of these infections in children are viral in nature. Around most of it are in now rash may appear. This may be a sign of viral infection, but thing that we need to keep in mind is that this rash may be a trivial viral fever rash, but sometimes it can be indicative of a more serious condition, such as in meningococcal meningitis. The petechiae may be a sign of meningococcal meningitis, but generally you may see a rash like this in the children, and mostly it is viral. So now another concern is in children is because paracetamol is a very good antipyretic agent and generally considered safe also. We've been using this paracetamol for several decades now. We know the dose, maximum dose, frequency which is required, but with the more and more use of or inappropriate use of paracetamol, even for mild, slight rise in the body temperature, we are seeing that the liver damage may happen because of excessive dosages or excessive use of paracetamol. So we need to be taking care. Then also I asked this question in the pre-test, and I was just going through the summary of the responses, and I found almost 60% of the
I'm
questions
sorry to
were
interrupt
attempted
you.
correctly.
Slides are not visible.
Uh, can you see now?
No, it's not moving.
Maybe you can,
It's on the communication barrier.
which one? Maybe you can start showing. You have my this thing.
Yes, ma'am.
Maybe the connection is not very good here.
Okay, ma'am. I'll
Because
share it from this side.
just share this. Now, most of the, I was just telling you, most of the questions were answered, around 60% were answered correctly, but that shows that there are gaps in this. Now, coming to, there are several preparations of paracetamol that are available in the market. It may be available as drops, syrups, chewable tablets, kid tablets, then adult tablets. Now, yes, move to, go on, go on, go on, go on. Yes, yeah. So there are, please go back. Please go back. Yeah, here. Oh, stay there, no? There are so many different preparations are available. Next. Okay. There are you just hold on there, no? Yes, here, yes. See, I have, purposefully put all these things, pictures here. They are all different strengths. So many of us, we have just learned that 5 ml or 3 ml or 4 ml of antipyretic will be enough. No, you should know the strength of the drug that is there in this formulation and prescribe. Nimesulide is also a very good antipyretic agent, but we saw most of the toxicity cases with nimesulide because people were overdosed with nimesulide. The dose of nimesulide was 1 to 2 milligram per kg, whereas the dose of paracetamol is 15 to 30 milligram per kg. So and we are used to giving the dosage in the form of mLs, 5 ml or so. So this can lead to toxicity. Next. And also remember that many of the anti-cold preparations also have paracetamol. Now also, many of us think that children are small adults. Is it true or false? Is my, Am I audible? Okay, false. Very good. Next, next, next. They are not small adults. Their body surface area is much bigger. So you must calculate the dose by milligram per kg body weight according to the different age groups below 1 month, up to 1 year, 1 to 5 years, more than 6 years, like that, and must know the strength of the capsule or a tablet or a syrup suspension that we are prescribing. Another thing that has happened after, particularly after the COVID pandemic, Dolo, this is another brand of paracetamol which contains 650 milligram of paracetamol. Normally, all the dosages that are given, as an antipyretic agent in adults, 500 milligram is enough. But unnecessarily, because this Dolo was brought in, this is for some specific conditions, pain, as a pain reliever in osteoarthritis patient, where we may be using this 650 milligram preparation. Now it has become a household name, and people are, even for the slightest rise in temperature, even below the threshold for fever, Dolo is being taken. So this also leads to overdoses. Next. Next. Yeah, and don't use this household spoons as a measuring device, particularly for children. This device spoon may vary from 3 to 4 ml to 7 to 10 ml. Household spoons are very much variable. So instead, and dropper will not be able to give a higher ml dose. So it is many times it is better that you use the calibrated oral syringe. You can accurately measure the dose, especially when the dose is less than 3 ml. So calibrated spoons are much better. Child also does not spill it around. You can administer the dose accurately to this the child. Next. Next. Okay, then liquids or injectable use of this, many times we presume that it is a child, that then we need to give liquid preparation only. It may not be true. If the child is bigger, 7, 8 years or 9 years, the child may be comfortable with taking oral tablets as well. So don't presume that, it's a child that you have to give liquid, or vice versa may also happen. So assess this individually and administer the dose accordingly. Now, and avoid injectable preparations in children, because they are painful, local infections can arise, and the child may get frightened. So better to resort to oral dosage forms as far as possible. Now, if it is a small child, the child may vomit the dose, so many times mothers, what they do is that mix the dose, milk or the feed, giving it to the child. Now you have to assess whether, paracetamol, of course, you can give, but other drugs, whether there is any interaction with the feed or not, ascertain that and guide the mother accordingly. Next. Next. Okay, how often do you administer paracetamol? How often do we administer? 2 hours, 4 hours, 6 hours, once a day, or whenever there is a high-grade fever, you can administer any amount of doses? I think there was one question on this also. So usually the dose is 6 hours, 6 to 8 hours, but sometimes the fever may not come down with the dose. It takes around 1.5 hours to 2 hours for the fever to come down with a dose of paracetamol. And many times, because the fever is high, the mother or the parents may get panicky about that the fever is not coming down. They may approach you that the fever hasn't come down, and we, to relieve their anxiety, we say, okay, give the another dose. But remember that you should not repeat the dose before 4 hours. 6 hours is the dose. 4 doses in a day is the maximum dose that you can give. So if the fever is not coming down, you need to look at the other reasons or the supportive treatment that may be used to bring down the body temperature here. Next. Then another area of concern with therapy is the antibiotics. Usually antibiotics are given 6 hourly, 8 hourly, 12 hourly, or once a day. But again, this may change because of the waking hours of the child. The mothers would try to give all the doses during the waking hours, but this may not suffice. So carefully look into this, because giving it too early, the dosages, the child may have toxicity because of this. So monitor or follow these things and the manufacturer's doses. Next. But usually in children, don't give a dosage regimen which requires to wake up the child from the sleep, because otherwise then the child may become panicky, and then it will be difficult for the mother to console the child. So here is, you can have this dosage chart with you, and the maximum dose here that you can administer according to the different age range. But generally is maximum dose per kg daily is 60 milligrams. That makes it 4 doses, 30 to 60 milligrams every 8 hours as necessary. Next. Now, there are, as I said, fever could be an indication of various underlying medical conditions. It could be bacterial, it could be inflammatory disorder or autoimmune diseases. Most of us have this misbelief that fever is a sign of infection. Fever does not mean infection only. It could be because of inflammatory diseases or autoimmune. So just don't blindly administer or empirically administer antibacterials to patients with fever. So there are 4 different categories of fever which will help us. For example, if there are localizing signs, chest signs are there, diarrhea is there, then you know which system is being affected. Or fever, if there are rashes or what is the duration, accordingly we can classify and find out the underlying reason for this fever. Next. So determining the cause is very important. Empirical treatment may be harmful. It may may be misleading, and the patient may unnecessarily deteriorate. Next. So usually you require a combination of history, laboratory test, and then follow-up. Risk of dehydration. Most of the time, fever does not come down because of the dehydration. If you are able to restore hydration, the fever will come down. And you also need to, even because during fever, there is a lot of perspiration. So dehydration risk is there. So you must keep assessing the child for the degree of dehydration and rehydrate the child accordingly. Next. Anxiety, of course, besides the child, you have to manage the parents because it can cause significant anxiety and misunderstanding of fever as a dangerous condition. They may keep coming to you in emergency and lead to overeat. You must address the parent. Next.
Ma'am, your voice is
Next.
not clear.
Okay, and don't over rely on temperature, only focus and look for other signs, clinical signs as well, because and you must explain to the parents about the red flag signs that they need to be watching the child, and whenever they see those red flag signs, they must seek medical attention immediately. Next. So monitor for complication. This is important. Just giving empirical treatment or antibiotic will not solve the problem. For example, the child may come up with the upper respiratory infection. And if you explain to the child, parents about the red flag signs that they progress to lower respiratory tract infection, the child may have tachypnea, or there is a intercostal recession, the child may be having difficulty in feeding. All these things are red flag signs, and if you prepare the parents properly, most of these things can be handled properly. And you must differentiate between fever of unknown origin, pseudo fever of unknown origin, or is it a true fever of unknown origin. Next. Many times we investigate, and also don't forget the cultural and home remedies. Some of them may be good, some of them may be bad. I remember, we have all learned through our cinema that cold water sponging should be done. In fact, this will increase the body temperature. If you have to do the sponging, it should be done with tepid water, warm tap water, so that the pores in the skin, they dilate and the body is able to release the temperature. Cold sponging may exacerbate shivering response in the body. So just, and sponging, यहाँ पर पट्टी रख लिया, वो कर दिया, वो नहीं करना है. वो dramatic scene picture में दिखाते हैं. That does not help. If at all fever is not coming down, it is always better to wash head and face, legs, as much as possible. It will bring down fever quickly. Next. Never use alcohol for bringing down temperature. There are herbal teas, onion socks. These are all myths. One should not resort to these things. These are not proven remedies. Harding's broths, soups may be helpful if the throat is bad, but you be careful about the burns or the scars that may arise because of the hot drinks. Next. I think I would like to end here. All of these things, you must look for evidence-based practices. There are several resources available for management of fever and FUO, standard treatment guidelines. We, with fever, most of the time I was trying to look at the guidelines. There are several guidelines for dengue, malaria, measles, mumps. Separate guidelines are there. But what we need is approach to management of fever. So we have strive to provide this kind of approach so that you can do investigation or evaluation stepwise, and without overusing or delaying any management. The stepwise approach will help. ICMR also has got this. Indian Academy of Pediatrics, they have developed some resources on fever. Any of these resources may be good. You can follow these, but just look at these. These are latest and updated regularly, and most of the areas of concerns I've already highlighted. Now I think Dr. Shobhna Gupta will be dealing with all these things in detail. You will find even more answers to your queries, and of course Dr. Anup Warrior will be talking about fever of unknown origin. Thank you.
Thank you, Professor Sangeeta Sharma, for setting the context. And all of you can, in fact, whatever your queries are there, you can write in the chat box. Then after this sessions gets over, we will address one by one. Now, with immense, in fact, happiness and the gratitude, we welcome Dr. Shobhna Gupta, who is the Deputy Commissioner in charge, Child Health and RBSK program, the Ministry of Health and Family Welfare. And we are very grateful. I would request my colleague, Dr. Siddhi, to introduce her, and then we can begin with the session.
Join camera. Good afternoon, ma'am. We welcome Dr. Shobhna Gupta, Deputy Commissioner and in charge, Child Health and RBSK, Ministry of Health and Family Welfare, Government of India. Ma'am is pediatrician by training and has 18 years of experience of working in clinical newborn and pediatric care in tertiary care government hospitals. As a national program manager, as a National Program Manager of Child Health and RBSK programs in India, she provides support and supervision for implementation of various programs. Under her leadership, Child Health Division has released various guidelines like faculty-based newborn care, training modules, facility-based integrated management of neonatal and childhood illness, IMNCI, and Pediatric Center of Excellences. She has a keen interest in implementation of early childhood development, birth defect surveillance, and related interventions for newborn and pediatric age group, and HBNC and HBYC. Also a member of WHO Technical Working Group on Burden of Birth Defects. She is a national faculty for various training like facility-based newborn care, newborn resuscitation program, medical certification of cause of death, ICD-10 coding, etc., and has presented papers, posters, and participated in panel discussions in various national and international conferences. We are delighted to have you here, ma'am. Over to you.
Thank you so much for the warm introduction. Sorry, something happened to my laptop camera, so I just for the starting part I have joined from my mobile. I'll omit from there, so my webcam is not somehow getting. First of all, I would actually thank you, the NHSRC, for providing this opportunity to connect with the medical officers and pediatricians across the country and talking about this important topic in their series of these lectures on the management of fever in children, especially the young infants. I would say is really very important, where we need to actually talk about in a more practical way that what needs to be done. The context has been beautifully set up by the Dr. Sangeeta. So I would be sharing my slides further.
Why should we share your slides?
Yeah, please share. I think there's some problem happening. I don't know at the red. If you have the slides now, please share from your end. Somehow this is also not being able to share. There is some issue at the WebEx end, I suppose. Yeah.
Yes, ma'am. No, we have shared the slides.
Yeah, sure. So I'll be actually omitting the just a second. Mm-hmm. Volume I can omit. Yeah. So okay. Yeah. So talking about the, as the context has been set up, if we talk about temperature, so everybody, knows what is actually a fever. By definition, if we say fever is auxiliary temperature more than 37.5, which is 100.4 degree Fahrenheit. This is by definition. And many a times when a patient actually comes to us, they take the oral temperature and they add 1 degree, or they come with 99.5, especially in children. So please, the definition of fever says it is 100.4 degree Fahrenheit for the intervention to act. And before that, we have to see many other causes, as we have heard in the last lecture also. So we need to understand why the fever happens. Actually, fever is a symptom which has an underlying cause. So it is a presentation of something going in the body, and it can be, which could be because of many causes apart from infection. Before we proceed further, I really want to highlight that in the newborn period, the symptom fever, both as we say, is 100.4 degrees Celsius. Similarly, Fahrenheit. Similarly, fever in a newborn can be because of hypothermia also. So the sepsis or infection in a newborn present most of the time is as hypothermia rather than as fever. So when we talk about young infant, the management of temperature balance in a young infant, suppose a 2-day-old baby or a 7-day-old baby, so till newborn period, we talk both about the hypothermia and the hyperthermia. That means the temperature below 37 and the below 37.5, both are important. Definitely, it is uncommon, and mostly when the newborn becomes sick, they mostly come with hypothermia, that is a low temperature. So we should be knowing when a mother is taking her baby to the hospital and is bringing, so we need to see whether the baby's peripheries are cold, baby's abdomen is cold to touch, or the baby is warm to touch. If both the peripheries as well as the central abdomen is cold to touch, that means it is a severe hypothermia and it needs to be taken care of immediately. Fever in a young infant, if a young child is coming with a high-grade fever, it generally indicates a possible serious bacterial infection, and it could be the only sign of a bacterial infection in a young child, young baby, as compared to a bigger child, which have mostly some come with a focus. So a newborn period, anything which the child comes could be a serious bacterial infection which needs to be taken care of seriously. Yeah. One important other thing which is common in newborns, many a times, especially in the first 7 days of life, even a term baby or a low birth weight baby, they can have dehydration because of the inadequate breastfeeding or the inadequate milk intake. So the child present with a dehydration, and they generally come with a dehydration fever. However, we end up giving, they're saying slides are not visible. So kindly check, is it not visible?
Yes, ma'am, we are checking.
Yeah. So if if a newborn is coming to you with a weight loss, with a fever 100, 100.5, then we need to see and ask the mother how is the intake of the child, how many times the child is breastfeeding. So minimum 8 to 10 times the child should breastfeed. How is the urine output? And instead of starting instantly giving, instantly the paracetamol or antibiotic, kindly look then how is the general status. Because in a newborn, the signs of dehydration might not be that visible. It is generally the weight loss, the urine output is reduced, the child is little less active, and it can give rise to fever also. Another important cause of fever in young child can be the environmental, especially in the month of June, in the areas where the atmospheric temperature can go more than 50, 55, especially in southern India. There also, the newborn baby and the young infant can present with fever. So we need to rule out that and to take care of the environmental causes also. Next slide, please. Yeah. So what to ask? When the child comes to you, what is important? The fever duration is very important, since how many days the baby or the child is having fever. Is this fever is associated with any localizing symptom in the form of respiratory tract infection or urinary symptoms like burning, micturition, or GI tract infection like diarrhea, loose motions, vomiting, or any severe infection like in the form of headache, vomitings, or in severe cases the seizures. If the fever, especially in a older child, is associated with any rash or symptoms in the joints, skin, or soft tissue swelling, then in young infant, fever can also be there because of the vaccination which had happened in the last 24 hours, like especially common are the pentavalent vaccination, which can give rise to fever, or even the measles vaccination can give rise to mild cough and mild fever, or any drugs or the toxin exposure which has happened. And also the family history or the neighborhood history becomes important, like in the cases of malaria or the dengue or any tropical illness being spreading around. So these important components should be the part of the history while talking to the family when they present to the OPD. Next slide. Along with these signs which we are asked in the history, it is very important to ask the mother as well as look in the examination for certain danger signs, or we can say the red flag signs, which actually should alert us for immediate stabilization and referral to a higher center, or in the emergency treatment if we are already in the secondary care. These are extreme lethargy. A child which was very happy playing few days back, it becomes lethargic. The child looks drowsy, or there is excessive cry or irritability, and the child inconsolable. Then second important point in children especially become vomitings. Because if the oral intake is poor or the child is not able to accept the feeds, there is refusal for breastfeeding. It becomes really important to see that what is causing that. The cause of CNS like headache, neck stiffness, or any difficulty in breathing, the respiratory rate rises, there is retraction in the chest, excessive cough, again is an alert. Any abnormal body movement or abnormal behavior of the child in the form of seizures or any abnormal body movement which the mother cannot explain needs an investigation. Temperature above 104 degree Fahrenheit definitely is an instant alert, and any fever, high grade, persisting for more than 5 days definitely needs investigation in young infant. So these are the alert signs which should be taken care of. Coming to the examination, yes, the basic examination of the vitals. Vitals are very important whenever a child or a young infant comes to you. Never ever, temperature has to be taken through a thermometer. You please see the heart rate. Although fever can already cause a baseline increase in the heart rate around 10. However, a very high heart rate needs to be seen. Respiratory rate to rule out pneumonitis. Blood pressure, if possible, in a bigger child. And a smaller baby, capillary filling time. Appearance is very important. When a child comes to it, we always talk about how the child looks. Is it toxic looking or a sick looking child? Toxic looking child means you are seeing the child looks, even a 10-year-old can look like lethargic, not eating, very suffused, especially when you see us sometimes in severe cases of dengue and typhoid fever. When the child, you can see the child is not accepting. So a toxic and a sick looking child who is very lethargic, irritable, or dehydrated needs admission and investigation. Please try to localize and see for the focus in the form of general examination. Always see the ears of the child, whether there is any pus, for the nose and the throat, whether congestion in the throat or any tonsils which can be visible, any rash on the body in the form of petechiae, any papules, a vesicular rash, especially if chicken pox and other things are going on, any lymphadenopathy. Cervical lymphadenopathy is quite common with upper respiratory tract infection. Look for the pustules and the pyoderma. In some of these settings, if you see these skin infections like pyoderma, you can see the pustules, the pus-like things on the body, impetigo. Look for the joints, especially girls, 10-year-old, coming with the high-grade fever. Look for the joints, that are the joints inflamed. There is a swelling and tenderness in the joints. We often miss the genitalia. It is a very common myth, and we most often do not check for the genitalia of a child coming with high fever, which is very important. There could be erythema and tenderness, especially in boys, a sign of orchitis. So they need to be seen whether there is tenderness, whether the genitalia are red or there is any trauma. Look for the bone tenderness and systemic examination for the chest, abdomen, and the cardiovascular system and the CNS system. Next, please. Next slide. Next slide. Yeah. So these are just the type of thermometers I just showed. Although Dr. Sangeeta, I think, has already talked about this. So this is the digital thermometer, is the most commonly used and quite reliable, which we use nowadays. Next, please. So when it comes to the causes of fever, once we have done the examination, then we need to see that what kind of fever it could be. We often tell the fever as there could be fever without any localized signs, which the child generally comes to you just the complaint of fever, like in malaria, any infection which is happening, even in typhoid and urinary tract infection. Then there could be fever with some localized sign, like the child, like in pneumonia, the child would come to you fever with cough or difficulty in breathing. In upper respiratory tract infection, cough coryza. With meningitis, the child will have some type of headaches or vomiting. In otitis media, the child will have ear pain or some discharge coming out. Skin and soft tissue infection. Hepatitis, where the child will again can present you with vomitings, with a little jaundice, developing jaundice, and the pain in the abdomen. So this is a fever with localized signs. You can always look for these. Then there will be fever with rash. Again, quite a common problem, especially if we see in children of 1 to 5 years. especially in the measles. If you see, there is a history of fever with rash in a child who is unvaccinated at the age of 1 year, and there is a recurring, mostly in fever with rash, you will see the similar history in the neighborhood and in the other kids around that. So measles, viral infection, because they're highly contagious and they spread fast. Dengue, hemorrhagic fever, relapsing fever, typhus. Coming to the fever which lasts for more than 7 days. If a child is coming with the history of more than 7 days, then please look for some chronic causes like abscesses where there could be pus collection. Then it could be rheumatic fever in the area where the streptococcal is more common, the sanitation is not maintained, kala azar, tuberculosis, then any malignancy, infective. So any fever lasting for more than 7 days, it could be 2 weeks, 3 weeks, then it should alert you. If a fever is not going, and this fever lasting means you need to maintain a temperature diary. It has to be there continuously, and that charting needs to be done. Many a times patient confused कि हमें तो fever is coming बहुत दिनों से जी आ रहा है और बीच में 4 दिन 5 दिन नहीं आता है फिर आ जाता है. That is not fever. या 99 को भी fever लिखते हैं. So we should be very clear what we are calling fever. And generally, when a patient comes with a doubtful history, fever lasting for more than 7 to 10 days, we often tell them to maintain a diary. Please maintain temperature को record करके लाएं. Whenever fever comes, record the temperature, and whenever medicine is given, please record that so that you can have an idea what all is going on in the child. Next slide. Then what gives you clue to a specific diagnosis? If we have fever with respiratory tract symptoms, most of the times if upper respiratory tract infection happens, there is a upper respiratory tract runny nose along with that. So runny nose and cough. In some cases, like suppose diphtheria, you can see the membrane is there over the tonsils. Then again, pertussis like illness, there could be cough. If there is a cough is a different kind, like a barking cough, we often tell it's a croup type of. So depending on the type of cough and the symptoms, you can actually give the specific illness clue. Similarly, in the fever with rash, we have different kinds of rashes, which we often get diagnosis for, like the red macular papilla, जिसे बच्चा बोलते हैं, red हो गया ऊपर से नीचे तक, starting from the above. So measles, rubella, dengue, such kind of बच्चा पूरा red हो जाता है, maculopapular rash. However, in varicella, जैसे chicken pox, they have a fluid-filled vesicles. So the type of rash actually can give us the clue what could be the diagnosis. Similarly, mumps, arthritis may, there are joints involvement. Then there are specific autoimmune illnesses which can give rise to specific symptoms like the tongue peeling, skin peeling, lymphadenopathy. So there's a whole gamut of symptoms which we can put together to understand that what kind of illness it could be there. Next slide, please. Coming to the investigation, similarly, as we have defined that, where you look for the type of symptoms. So when the fever is less than 7 days and it is fever alone, means you don't have any localizing sign and symptoms in the form of respiratory or any no symptoms other than the fever. So if the child comes to you with less than 3 days of fever and the child is not looking sick, generally we wait and we do not order any investigations. So we have to just tell that we give the antipyretic for fever to settle down and maintain hydration. That is a lot of fluids and ORS. Because many a times it could be a prodrome viral infection which settles on its own. If the fever becomes more than 3 days, definitely then we consider and we order the complete blood count in the form of TLC, DLC and the peripheral smear to look for the morphology, malarial parasite and a platelet count. These are the basic we order for the 3 days. Definitely, if we are suspecting that there is an ongoing case of malaria cases are there and we have a strong suspicion, we may order for the malarial antigen and the NS1 antigen, depending on the seasonal variation and the type of cases coming to us and the symptoms the child is presenting with, and a blood culture. If the fever is less than 7 days and there are some localizing symptom present, some focus is present, then definitely as which we have essential we have defined in the first box. Along with that, we can add generally the urine microscopy and culture to look whether there is any UTI, because the symptoms of the urinary tract infection might be masked many a times. Always have a chest x-ray And if required, if it's a small baby like a newborn, then we do the CSF analysis also. Other optional things are being the pulse aspiration or the ultrasound. Again, that depends on the case-to-case basis. Fever being less than 7 days, having very non-specific symptoms, definitely, as we have defined in the desirable, they again, this we have actually already done, that we may order the other symptoms of scrub typhus. So first and the third box is essentially the same. Depending, so we generally, so the crux is that generally for less than 3 days, if the child looks normal, we do not order any investigation. We wait, we ask for antipyretics and a good fluid. If more than 7 days, then definitely we go for the battery of the test. So 1 day fever, 2 days fever coming to you, even very high grade, do not just jump on the test if it is not required. Next slide, please. Then if the fever, as I said, when the fever becomes more than 7 days, then we have other things in mind which are going on. So all those investigations which we have mentioned below needs to be done. But along with that, we need to think about the chronic and the severe diseases which might be underlying. So if a child is less than 5 years, we do order for the Montauk's test and we do an ultrasound. Ultrasound basically tells us that there is no underlying pus lying anywhere. So it rules out the kidneys and the liver. So the solid organ pathology is being taken care of and there is no underlying pus anywhere. Then these tests again become, which are known as optional, are definitely depends on your expertise and the level where the child is being coming. So definitely by the pediatrician, after examining the child overall, they may go for the advanced test for the fever workup to rule out malignancy, tuberculosis, any abscess. So these, the ultrasound, your CBNAT, bone marrow. So these all depends on the symptoms the child present to you after thorough examination and the preliminary investigation. And similarly, is for both the boxes, even with the localizing symptoms. So these CD scan and ANA profile, they all depend on the tertiary care hospital after a thorough examination by a pediatrician. Next slide. Coming to the management, actually, this is very important because, as I said, fever is a presentation of some underlying thing going on. However, it is very important the child's how the children are different from the adults, that the children can go very fast towards dehydration, hypothermia, hyperthermia can cause them seizure. There is an entity known as febrile seizures. So per se high grade fever can be detrimental to a young infant or a small children, so which is not the case generally in adults. So when a child is coming to us with a fever, we need to decrease the body temperature. So the first and foremost thing which we always tell to the parents, whenever parent will come to you that the is having X104, so please tell them do hydrotherapy with tepid. As Dr. Sangeeta also have told you, in India generally, hydrotherapy, they think that it is the cold water. They put the, in fact, ice, which is not to be done. It is the tap water or a lukewarm water which needs to be taken. And generally hydrotherapy, what the parents do, they just put it on the forehead, which is not correct. Please take the good hanky or a towel and just sponge the whole body of the child, the back, the abdomen, so the center, so the properly sponge the child with the tepid water, which is the best therapy to bring out the highest temperature to a normal level. Definitely, you need to give the paracetamol with 15 mg per kg, oral syrup or drops depending on the age of the child. See and manage any life-threatening issues, like if there is any, if you are in a facility, look for the pulse oximeter. If there is a drop in the saturation, we need to give oxygen. If the child newborn is coming is a newborn or a young infant, look for the blood sugar. If it is less, then definitely you need to give the 10% dextrose to the child. So those are the, you need to maintain the blood sugar. So we say TOPS, that is temperature, oxygen, perfusion, and sugar. These are the 4 important things especially when it comes to a young infant. So we need to maintain the TOPS. Always remember the mnemonic TOPS, because fever can be a presenting feature of an underlying severe illness, possible serious bacterial infection. So please maintain the TOPS. In case you are sitting in a far-flung area where there, you need to give the antibiotic dose, the facility, higher facility is far off, give the first dose of antibiotic as per our IMNCI protocol. In a suspected zone of malaria, we need to give anti-malarial. So I will show the chart booklet is there of IMNCI where, the decision when the child is coming, young infant is coming, what you need to give, or a child is coming. So we need to follow that. So the initial assessment and stabilization is really important, and which is very much doable. Even the child is, even if you are referring the child to a higher facility. So please give these 3-4 things. Then when to consider hospitalization for observation or management. So definitely if a newborn is coming with a hypothermia or a hypothermia, so please maintain that they need to be observed to look for the other signs. Any young infant with toxic appearance or any danger signs, they need to be seen. Child with severe malnutrition, inability to feed, lethargy, irritability, dehydration. These are all which needs to be considered for hospitalization. Any child presenting with more than 14 days of illness and has not been diagnosed, the reason definitely needs an admission. And any reason, if as a treating physician you think that something is not right and this child needs hospitalization to carry out, need to be considered. Depending on the facility you are working at, you might be in a private facility or in a secondary care or a primary care. So consider referral to a tertiary care center, but after the step 1 has been taken, that is appropriate stabilization and initial management. Mind you, the children do not have that reserves. If you send a child or refer a child without settling down their high grade fever or temperature or oxygen need, even if you refer, the child may not be able to make it, or even if they make it at a higher facility, they are in such a bad condition that even after revival, the outcomes are not good. So it is my humble request to please settle them before referring to a higher facility. Look for the paracetamol, hydrotherapy if it is there, sugar, and the oxygen need. This is a basic minimum you need to do, and a first dose of antibiotic if you suspect strongly sepsis. So need for intensive care, and intensive care in the form of non or invasive or the non-invasive ventilatory care. You think that it is a multi-system complex disease, and you think it is a complication of a primary illness, you may need to refer to a higher center. Next, please. Then empirical management, definitely the management depends on the likely diagnosis, the sickness status, and the availability of the investigations which we have decided. So it should be, the empirical treatment actually should not consist of all the things. It should not be the blanket therapy. It depends, even if on initial suspicion, if we have started our antibiotics and we think later on we found out that it is some other reason for which in a young infant we have started antibiotic, but we thought that later on it is a dehydration or any other thing which has caused the fever, and our reports have come out negative, the blood culture and the other reports have come normal, then those should be tailored. Those should be stopped, and the supportive treatment in the form of good feeds, hydration therapy, and counseling should continue. So we need to tailor, even if we have started anti-malarial or other things, we find out that the investigations are negative, please tailor the therapy as the investigations keep on coming, and once the diagnosis is confirmed, only those treatment need to be continued. As you all know, ATT not to be started on empirical treatment except in the suspected tuberculomeningitis in infants. Otherwise, it not to be, and currently we have good amount of CB-NAT machines and good diagnostic kits available. So definitely the diagnosis of TB is becoming much more, confirmations are available, and the things are available. So we should not give rise to the resistance, and we should be able to give them the diagnostic after confirmation. Then consider hospitalization or observational management if when do sorry, this is, there has been some this should be considered discharge. There is some mistake in the heading. So when the child is afebrile for more than 48 hours or fever is showing deficits, so when do you consider that the child can be sent home? So more than 48 hours of afebrile period. Very important in child is criteria is a feeding well. So in fact, the criteria for hospitalization as well as discharge in young infants is many a times whether the child is feeding well. So if the child is not eating well, the many a times the only indication is actually because of this. Otherwise, we have oral antibiotics. So please take care of the general condition. The child is active, afebrile, the presenting symptoms have resolved, and as a treating physician, you are satisfied that the further care or the oral antibiotics or the oral medicines which can be continued on OPD basis, and the child is completed of any IV antibiotic or IV drugs which are being running. Next slide. So we have all learned what to do. So what not to do in fever? Please do not overclothe the child. Often we have seen that we overclothe the mothers, overclothe them more. Do not overclothe the child. Give him in a ventilation, airy environment. Cool does not mean the AC, but the airy environment. The temperature 26 to 28 degrees Celsius is good. So do not overclothe and maintain the ventilation. As I said before, do not sponge with cold water or ice. Always use the tepid water. So you will obviously not measure the temperature, but the general warm water coming in the tap water or in winter months, a mild lukewarm water is good enough for a thorough sponging. We do not use aspirin or nimesulide for control of fever. Paracetamol is the safest and is good enough. You give 15 milligram per kg 4 to 6 hourly, it is being safe, along with hydrotherapy. So this is a therapy we use even for the high grade fever. And always consult a pediatrician at the earliest. Do not keep treating fever at home or by yourself. It is not resolving. The child is looking toxic, and especially in a young infant, less than 1 year, less than 6 months. Please at least show once to a doctor to, tell your patients to actually show to you if they are not improving. Next, please. Yeah, next, please. Next, please. I'll just show you the IMNCI chart booklets which are available. See, in the IMNCI, that is the Integrated Management of Neonatal and Child Illness, we have two algorithms. One is for the sick young infant, which is aged up to 2 months. So this booklet is actually for all the persons working at the level of the primary health centers and even above, and even in our MBBS students. This is there in the in-service course. So there, in a young infant, as I told you, that fever is often a symptom of one of the possible symptom of a possible serious bacterial infection, which we often call as PSBI. So one of the symptom, if you see here, measure the axillary. So if the infant is having feeding in difficulty, is the infant had convulsions. So there are the things which have been mentioned. So as fever is one of them, we generally follow, if you follow this booklet, then it is very easy to see that you count the breaths in 1 minute. For a young infant, till more than 60 is abnormal, is fast breathing. So if it is still 60, it is not fast breathing, it is normal. So look for chest in drawing, then measure maxillary temperature. If you are not able to measure the axillary temperature, feel for fever or low body temperature. How do you feel? You take the back of your hand, you put it you touch the peripheries of the child, and then you touch the abdomen of the child. If there is a difference in both peripheries and abdomen, then the child has cold stress. If both are cold, then the child is having hypothermia. So see, it is written, is it less than 35.5 degrees Celsius or 37.5 degrees Celsius or above? So in a sign of possible serious bacterial infection, both hypothermia as well as hyperthermia, that is more than 37.5, has been seen as a local, which could sign of a bacterial infection. Then again, what are the young infant's movement? Does an infant move only when stimulated, but then stop? Does the infant does not move at all? So what is the spontaneous movement? Umbilicus is red or draining pus or any skin pustules. So out of this, if only the skin pustules are present, we call as local bacterial. If any of the other thing is present, So definitely it's a sign for possible serious bacterial infection. Next slide. Oh, it's actually very, it is, it is one of the symptoms which I showed you. So it is, next slide, next. So this is again the general danger signs, which I have already told you, that the child is lethargic or unconscious, fast breathing is there, sunken eyes. So this is again the management of young infant 2 months to 5 years. So this is the general signs, vomits, everything. Next slide. This is how the chart booklet looks like, that you assess for the signs, ask, look, and these are the signs, and then classify as. So this is the pink classification, yellow classification, and the green classification. So we classify as possible serious bacterial infection or a very severe disease, pneumonia as yellow, and then infection unlikely as green. So if any of the symptom which I just talked about, including the fever, is present, so we classify. So auxiliary temperature 37.5 or above, or feels cold to touch, again comes as a PSBI, and we give the relevant treatment. So this is actually a decision support system kind of thing, which you can see that you are assessing, you are seeing the sign, classifying, and then identifying what treatment to give. So the fever comes under this category, pink, in a young infant. Next slide. So again, this is the same thing, which is this thing that does the child have fever by history, or feels hot or temperature. So this is, you ask, you feel, and then you classify fever. And it could be very severe disease, malaria suspected, or malaria unlikely, and the corresponding treatment. Similarly, so these are the categories: dengue fever of 2 to 7 days, which we have actually discussed now, and whether it is with measles. So on the base of these categories, so this chart booklet actually tells you how to go. So even, basically this chart booklet helps you to see for the symptoms, then tell what to do next. So they tell you the stepwise decision to be taken, whether to admit, to send home, or to treat. Next slide. Yeah. That's it.
Thank you so much, ma'am, for the insightful session. I request, if you have any queries, please post in the chat box, and we will take it at the end of the session. Now I request Dr. Anup Warrior to take the session on the fever of
Am I audible?
am I audible?
Yes, you are audible. Can you hear me?
Yes, sir. Yes, sir.
Okay.
Thank
Can you
you.
share my screen?
If you have, so just a minute.
Yes.
If you have any queries, please post it in the chat box. And now I request Dr. Anup to take session on management of pyrexia of unknown origin. Sir is senior consultant in infectious disease at Aster Medicity, Kochi. He's leading the hospital infection control and antimicrobial stewardship program, and is also the chief of medical affairs and quality with Aster DM Healthcare India. With over 18 years of teaching experience and more than 15 years of experience in infectious diseases, he has received fellowships and certifications from various national as well as international institutions like PD Hinduja Hospital, Mumbai, Royal College of Physicians, Edinburgh, to name some. He has also received Society of Healthcare Epidemiology of America, International Ambassador Award 2015, and a research grant from Society of Healthcare Epidemiology of America in 2019. He is also a two-time awardee of Healthcare Management Asia Awards in 2016 and 19. He is also an author of the API textbook of adult immunization and various other textbooks. We are delighted to have you, sir, today. Over to you, sir.
Thank you. So, are my slides up?
Yes, sir, your slides are visible.
Thank you. So, good evening all. So for next 30 minutes or so, I'll be taking you through the workup of fever of unknown origin. So this was one of the statements which came in a publication in 2025 about FUO. So the statement was, despite all the medical advances since the report in 1961. So 1961, the Spittersdorf report was when FUO was defined with a structured, duration and what investigation, etc. What kind of temperature should be defined as FUO and all. So it was the structured definition of FUO came in 1961. So from there, the art of medicine is perhaps not better appreciated anywhere more than a core principle on FUO diagnosis. So what this statement tries to share is that in spite of all the technology and availability or access to diagnostics, even in the best part of the world, 20% or more remains undiagnosed. The percentage of undiagnosed FUO has not come down significantly, and it has been one of the biggest challenges for a physician to, with history, physical examination, what kind of tests to be done, and to get to the root of the cause of the fever and treat it. So in my talk today, I'll be sharing what is the definitions of FUO as which is available, the causes as we know around the world, what are the workup or diagnostic algorithms available, and where do you place some inflammatory markers like ESR, CRP, and procalcitonin, ferritin, etc. So classically, fever of unknown origin is divided into 4 groups. The classic FUO, the temperature is 38.3 degrees Celsius or higher, recorded on several locations, and the time period which they ask for is more than 3 weeks. Both outpatient visits or 3 days of in-hospital stay. So I have a better chart which puts up how the definition of FUO has evolved over time. That is the classic FUO. So today we are discussing the classic FUO. We are not discussing nosocomial FUO nor neutropenic FUO or HIV associated FUO, because these have very different etiologies and different kinds of diagnostic tests. So that's a totally different section or discussion altogether. So today we are going to discuss classic FUO. A good number of data of what I'm going to present to you today comes from this publication in British Medical Journal just last month, BMJ 2025. So as I was mentioning, the different definitions of PUO starting from 1961 to the latest, which was published in 2024. So for most of them, the temperature threshold has been very, very similar, either 38 degrees Celsius or 38.3 degrees Celsius. The fever duration also has been pretty much same, more than or equal to 3 weeks. The evaluation setting, initially it was predominantly focused on inpatient. In 1991, 1997, since 2024, both inpatient and outpatient evaluation has been included. The duration of evaluation was 1 week initially. It changed to 3 days in 1991. The fever evaluation duration is no longer mentioned in the definition after that. A minimum set of investigations were not recommended in the initial definition 61 and 91, but from 1997 to 2024, a minimum set of diagnostic investigations are required before you go ahead and label something as an FUO. And what are these? We will come in a short while. But so majorly the differences are over time. Though the temperature threshold and the duration of fever remains same, the evaluation setting, outpatient, has been added. The duration of evaluation, that means should you evaluate for 3 times, should you evaluate for 3 days or 1 week, that has been eliminated completely. And something like a minimum set of investigations or lab tests have been included. Upfront itself, it is very important for you to differentiate between persistent fever versus recurrent fevers. So recurrent fevers are mostly autoinflammatory diseases, and many autoinflammatory diseases can present in adults also. The most common, which all of us know, is the familial Mediterranean fever. But there are, as you can see on the right side column, there are a whole lot of autoinflammatory syndromes which can present in adults. Some of them have very specific clinical manifestations like aseptic meningitis, uveitis, hearing loss, etc. Some of them may have just fever in between. So please remember that you should differentiate between persistent continuous fevers which happen every day or every alternate day like that, and recurrent fever which have long gap in between. Sometimes rare genetic abnormalities also can cause fever and a higher susceptibility to bacterial infections. So just to highlight that there are so many things that we still do not know, and as I was mentioning, even in the most developed world and even with the maximum investigations possible as of today, still 20% of the FUOs remain undiagnosed. So this is a snapshot of the causes of FUO in around 21 countries. This was published in 2023. So more than half of them remains infectious diseases. The next largest chunk is actually undiagnosed, 20%, which I told you, followed by malignancies, then vasculitis or collagen vascular diseases, and finally a lot of other miscellaneous causes. So basically we are dealing with these 5 categories: most likely an infectious, followed by malignancies, vasculitis, and then a whole lot of smaller causes, and as I was mentioning, 20% remains undiagnosed. Since infectious diseases are the common cause in the FUO, we also looked at the infectious causes in developing countries. So of the infectious causes, what would be the commonest? Again, this was published in 2024. So TB was the commonest cause of FUO in a developed country among infectious diseases. Okay, so we should not confuse this with the most common cause among all the patients. No, TB was the most common cause among those patients diagnosed with an infectious syndrome. Okay, obviously, there were non-infectious syndromes in the rest of the population, followed by infective endocarditis, malaria, where it has been endemic, brucellosis, and typhoid. Similarly, this was a publication of more than 2,500 patients distributed among various WHO geographic regions. So we look at the Southeast Asia, and among infections, you see that 48% was in the Southeast Asia was tuberculosis. This is very closely followed. The next most common was endemic fever, typhoid. Okay, so in our setting, TB is followed by typhoid, and then visceral abscesses. Among the non-infectious inflammatory diseases in our part, so Southeast Asia is the third one. Adult onset Still's disease is the most common, followed by SLE. Okay, so adult onset Still's disease is something which we should definitely remember being one of the commonest causes of non-infectious inflammatory disease. Among the malignancies, the top 3 are Hodgkin's lymphoma, non-Hodgkin's lymphoma, and leukemia. We have some percentage of drug fevers also, but majority is lymphoma and leukemia. So undiagnosed in Southeast Asia was about 15% or more. And I would like to again point out to this Kikuchi syndrome in 26% of the miscellaneous causes. So among non-infectious and then again hemophagocytic disorder or HLH or macrophage activation syndrome. So what I would like you to remember or take back is that among the non-infectious inflammatory diseases, remember adult onset Still's disease being very common. Hematological malignancies like Hodgkin's lymphoma, leukemia, and non-Hodgkin's lymphoma to be looked at. Then Kikuchi syndrome and HLH or macrophage activation syndrome to be thought of when these are not there. Just a publication from the Indian perspective. TB we have already discussed. Something which was not there in these publications was scrub typhus. So this was a letter to the editor which highlighted that many cases of FUO also ended up being diagnosed as rickettsial diseases or scrub typhus. The type of or the causes may differ as per the income level of the patients. So at higher socioeconomic strata, non-infectious causes may be predominant, and at lower socioeconomic strata, infectious disease may be predominant, basically because of the risk of transmission and acquisition. The other thing which was coming up was that if you include minimum diagnostic tests that is what they call as qualitative criteria, then you will have a higher proportion of undiagnosed illnesses. Vis-a-vis, if you don't include, it's only time specific, that is quantitative criteria, that's only 3 weeks of evaluation without any minimum diagnostic test effort, then we end up with more of infectious diseases. So this is important because when you do a study or read a study, it is important for us to look at what is the definition of FEO that they use. Did they include minimum diagnostic tests in their criteria, and only when minimum diagnostic tests were negative, they considered it as FEO, or they considered any fever which presented to them beyond 3 weeks at FEO. So what are these minimum standard of tests before declaring as FEO? Laboratory tests, CBC with differential metabolic panel, including calcium and liver function tests, creatinine, etc., ESR, CRP and ferritin, the inflammatory markers what I spoke about. Minimum of 3 sets of blood cultures, and we need to wait for a full incubation of 5 days. Urine analysis, and if pyuria, to go ahead with urine culture. And a latent TB screening with either a MAN2 or an interferon gamma release tests. Imaging test, they ask for an imaging of both abdomen and chest. CT is preferred to ultrasound and chest x-rays. So there are certain clinical clues which are commonly seen and associated with certain diseases. But what we need to understand is that though these clinical clues are specific, that means if you find these, it is likely that yes, you are looking, or you are most likely facing this particular disease. Like for example, if you have lacrimal gland enlargement, it could be Sjogren's or RA. Similarly, if you have generalized lymphadenopathy, EBV, HIV, hyper IgD, etc. But absence of these does not mean that this disease is not there. So we should remember that many of the typical signs which is described, like Roth spots for endocarditis, etc., are specific but not sensitive. So in most of these patients with this, you may not find it at all. The second important point in this slide is that when we say potential diagnostic clues, it refers to the history and physical examination. So in the most of the series, the most helpful part, other than the medical and surgical history, was history of weight loss, and in physical examination, a heart murmur and auscultatory findings in the lung, any chest signs, abnormal chest signs. But we should also remember that in the first series of 167 patients, nearly half of these clues were misleading. So meaning you found splenomegaly, you thought of something, but it did not lead you there at all. And similarly, in another study of 73 patients, more than 80% of these potential clues may be misleading. So what does this tell you? I put this up specifically because a pure clinical diagnosis is extremely difficult in FEO. A pure clinical diagnosis without any additional tests or without any specific tests, coming to a conclusive or diagnosis based on pure clinical history and physical examination is little tricky, is difficult. Many of these signs and symptoms may mislead you, and you may be actually facing another infection or a etiology than what you thought at first. So that is the reason why investigating and establishing the diagnosis with the right investigations is important when you evaluate and manage an FEO. So that's the reason why I put this up specifically. Some of the etiological tests are some of the etiologies or causes of FEO are very, very difficult to diagnose. So intravascular lymphoma is called as a great mimic. It can come up as mass lesions, as sepsis mimicker, as PUO with hepatosplenomegaly. So a lot of clinical presentations are there for intravascular lymphoma, and diagnosis is very difficult unless there are frank skin lesions from which you can biopsy and find out the etiology. It's very, very difficult. So recently, in last year itself, this publication came up for a screening tool. So they suggested that if the WBC count is less than or equal to 7,200 and the lymphocyte to monocyte ratio is less than or equal to 3, there could be chances that it could be intravascular lymphoma. But basically, this screening tool had negative predictive value. That means what they proposed or what they found out was that if both these, that means WBC count is above 7,200 and lymphocyte monocyte ratio is more than 3, then the chances of intravascular lymphoma was basically 0. So this is why I highlighted it, because otherwise screening and identifying intravascular lymphoma is very difficult. even though in India, tropical infections remain very common, including TB, leptospirosis, brucella, rickettsial infections, etc., the diagnosis is not easy. Why it is not easy is, one, CAR tests have a lot of fallacies. Both sensitivity and specificity of CAR tests have a problem. PCRs, which are very specific, are not sensitive for many, and accessibility to PCR is a problem. Serologies have cross-reactivity and also long persistence in a patient. That means if somebody is dengue positive, IgM could be present as long as 3 to 6 months. And somebody who has had leptospirosis, his leptospira IgM could be persistent from 6 months to 1 year. So having an IgM positive does not establish the disease. Lack of serologies don't establish the disease. Some serologies, 2 or 3 serologies may be positive due to cross-reactivity. PCR's access is a problem and sensitivity is a problem. CAR tests again have their own fallacies. So that's why, even though we say tropical infections as common cause, and many times we do empirically treat these tropical infections. Coming to the workup, so this is one of the recent publications which has proposed an algorithm. So obviously we start with a comprehensive history and physical examination. If there are potential diagnostic clues like unpasteurized milk and rest of them concerning brucella, send a brucella serology. Similarly, if there is a heart murmur, new onset, early cardiac failure, then get an echo first. So that is, if diagnostic clues are there, directly go to the focused diagnostic tests or diagnostic studies. If nothing, that means history and physical examination is not giving you any clue, go for a panel of tests: CBC, CRP, ESR, ferritin, TSH, ANA, HIV serologies, hepatitis workup, urine analysis, IGRA, blood cultures, etc. And the CT chest and abdomen, along with a transthoracic echo if we have not done that earlier. In this, if any positivity comes up, that means either in your the TSS showing thyroiditis, or blood culture showing typhoid, or CT chest abdomen showing lymph nodes which could be turned out to be TB, or echo showing endocarditis, etc., then you do a focused study. So if there are lymph nodes, go for lymph node biopsy. If there is a lung infiltrate, get a bronchoscopic lavage. Again, if there is nothing, you repeat the process. Go back, revisit the history and physical examination. Again, look at what, because things tend to change over time. Sometimes you pick up new things in the history. Sometimes new clinical signs start appearing, which could point you towards the diagnosis. That's why we repeat it again. Then you do not get anything even after this, then go ahead and perform a PET CT. Now, if PET CT is negative, something of reassurance is that people who have negative PET CT usually tend to do well. The fever, etc., resolves on its own in these patients after you come to this step. So this was a structured algorithm, but there was a systematic review and meta-analysis which published in JAMA, which looked at workup using a very structured algorithm like the step 1, step 2, step 3, or we decide based on the clinical situation, based on the patient, based on the geographical location, based on what signs you get, etc., etc. And they found that there was no difference in yield. So what I'm trying to say is that it is not required that you have to adhere to any very strict protocol. You can develop your own protocols. There is not much difference between the yield between an internationally published algorithm vis-a-vis what you evolve from your common sense. Something which we need to be aware of is the need to go for tissue for diagnosis. So anytime you find a localization like a mass or a node, please get that tissue for biopsy. The tissue-based biopsy yield is around 50%. So this includes bone marrow biopsy also. Okay. So this is called something called as a Sutton's law. That means you go where the yield is maximum. So if you have a abnormal mass, lymph node, or an abnormal marrow, etc., the yield from that biopsy is going to be the best. So and that the best is around 50% or so, but that's what we need to focus upon. So do not hesitate or back out from going ahead with invasive diagnosis instead of going for empiric therapy. There are certain new tests which have come up. A lot of labs are doing metagenomic next generation sequencing in patients with FUO. So and even multiplex panels. They commercialize and they market this as FUO panel. So these FUO panels and if you're using NGS, had sensitivity of 91%, but please note that the specificity was only 64. So that means nearly half of the time they would give you some wrong or misleading reports. Specificity is only 64. So what you get in that is right only about little more than half the time. In rest of the percentage, it would be misleading or wrong. So this lack of specificity is something to be remembered when you are asking for an NGS or a multiplex PCR. Now again we have something called as a microbial cell-free DNA sequencing. So this is the most latest one. This was published again in February 2025, just this year. So again, they found out that only if you have leukopenia and high Charlson comorbidity index, CCI, Charlson's comorbidity index is when people are sicker with more comorbidities, then the yield is better. And when you have no localization, the yield is low. Basically, but we require such kind when there is no localization, right? So again, clinically, the impact of this has been very good. So the newer techniques like NGS and liquid biopsies, etc., has not proven to be very useful. So this was the latest definition and a consensus statement on management of FUO published in May 2024. I will just go through the top 3 recommendations. The first was that clinicians incorporate geography and prevalence of diseases in the geography when considering diagnostic testing. So that's why TB, typhoid, etc. are important for us. So we will consider that high and evaluate first for these diseases when they come to us. Second recommendation is about the duration of 3 weeks and completion of the minimum standard diagnostic tests. So we discussed that, what are the minimum standard diagnostic tests. And the third thing, very important, which is a change from the algorithm we saw, is that consider PET early. So if you diagnosed a PUO that is more than 3 weeks and your minimum diagnostic tests are negative, go ahead and no potential diagnostic clues, go ahead and do the FDG PET instead of the traditional CT chest and abdomen. So we used to do CT chest and abdomen about 5 years before, but now all of us are doing PET CT as the second line, not as third or fourth line. So since this has changed the management of FU, so we pick up a lot more since we have started using PET. And in 2024, there was a consensus document on how to use PET in PUOs. The patient needs to fast for 6 hours, at least 24 hours if you are looking at endocarditis. So cardiac imaging requires more fasting and a high fat, low carbohydrate diet. His sugar should be less than 200. If the patient was on steroids for anything empirically, for immunocompromised state or whatever, you need to discontinue steroids for at least more than 3 days. Empiric antibiotics don't affect the PET yield so much, so that's fine. You need to stop antibiotics before scanning. Contrast is not mandatory, so you can do a low contrast, no contrast, low dose CT with FDG PET, so that's acceptable. So abnormal creatinine value should not pull us back from using the PET CT. The diagnostic yield is 50 to 60%. The positive findings will guide for us for a specific therapy, and negative, as I was telling you, spontaneous remission is very, very likely. So if you read the last sentence on the left, it says that among patients with FUO, patients with a PET negative status are approximately 6 times more likely to have spontaneous remission than patients with a positive PET. Okay, so negative PET is not a bad thing. You can reassure them that that means mostly it should resolve. When should empiric therapy be used in PUO? This is again from the BMJ. So there are only very, very limited this thing. One is if the patient is septic, we start broad spectrum antibiotics, obviously, if the patient is septic. Suspected giant cell arteritis with visual symptoms, steroids need to be started fast. TB, even though mentioned in Indian setting, we do not go for empiric treatment for TB in the age of CB-NAT and gene expert being available. We prefer to evaluate, including with invasive diagnostics, to prove TB rather than go for empiric ATT. The role of inflammatory markers is very, very limited. Okay, very, very limited. Something looking at the literature, what I could gather was that ferritin tends to be low if it is purely infectious cause. Procalcitonin tends to be high if it is again purely infectious cause. And here ESR remains to be more than 40 in almost all cases of malignancy. So of this, something which is maybe practically useful for us is that the ESR is normal, unlikely to be a malignancy, or less chance of that being a malignancy. That's only take back from the inflammatory markers part. So I will close this discussion with a snapshot of my personal approach of FUO in my practice. And I was saying, compared to a structured algorithm, we have the JAMA systematic review meta-analysis, which says that yield is not better. So all of you can come out with your own common sense based algorithms, how you want to evaluate your patients in your setting. So the first thing which I do is I rule out sepsis. So it can be due by clinical examination or through objective SOFA scores. If the patient is septic, obviously we will be admitting. Empiric antibiotic will be started as per syndrome. Usually in my setting, it is meropenem plus doxycycline. Why meropenem plus doxycycline? I need to cover typhoid. Meropenem will cover that. I don't need meropenem for typhoid, but I need to cover melioidosis also. Melioidosis is also a possible cause of FUO in my endemic or in my setting. So that's why meropenem to cover melioidosis. Atypical infections like scrub typhus, mycoplasma, these are covered with doxycycline. So meropenem doxy is my choice of an FUO in a sick septic patient. I screen for the sepsis mimic at admission itself, because we know that adult onset Still's disease, SLE, etc. could present as sepsis, but they require immunomodulators. So they won't respond to antibiotics. Unless you add immunomodulators, these patients will die over the next 2 days. There are also other causes, infectious causes that require immunomodulators, like multi-inflammatory syndrome, MISA, or post-COVID syndromes, inflammatory syndromes in adults and children, toxic shock syndromes. So MISA and toxic shock syndromes, we screen with a criteria. There is a criteria for MISA, criteria for toxic shock syndrome, strep and staph. And if these are there, then we add immunoglobulin and hydrocortisone. Since we do not we have not ruled out frank bacteremic sepsis, IVIG does not do much harm, but hydrocortisone we give it only sepsis dose until we prove that it is non-infectious by negative cultures, etc. At a dose of hydrocort 300 milligram per day. Now, if there is no sepsis, we look at the inflammatory markers, ESR, CRP, procalcitonin and ferritin. If procalcitonin is low with CRP or ferritin high, we do a TSH. Mostly TSH is also a part of the minimum diagnostic test. So, but thyroiditis is something which you should not miss. So thyroiditis patient will have fever with no localization. Sometimes they will complain of neck pain or neck tenderness, may or may not. They may not even have profound tachycardia. But TSH is a simple 100-300 rupees test. Without doing that, if you go for PET CT, we will look funny afterwards when we diagnose thyroiditis. So I may keep it in mind and definitely roll out thyroiditis before I go in for a PET CT. If the PET CT is normal, then there are certain infections which can be normal or which cannot be identified with PET CT. So for endocarditis, that is native valve endocarditis, PET CT sensitivity is under 50%. Transesophageal echo is the most sensitive of native valve endocarditis. Brucella serology is because Brucella culture pickup may be poor. Again, typhoid serologies like Vidal may be useful here. So here, we do a trial of ceftriaxone and doxycycline. This is because my area is not in malaria. So in an area endemic for malaria, I would have to add anti-malaria, but in not ceftriaxone is my preference here. Now, if the PET CT is normal, no with high ferritin, CRP, ESR, etc., we consider adult onset Still's disease if the patient is young, that is under 40 or 50, and polymyalgia rheumatica or giant cell arteritis if the patient is 50 or above. Okay, so though I can't call them as elderly, the PMR GCA criteria starts from an age of 50 plus, especially if the ferritin is high. Now, if the PET CT shows localization like a mass or a lymph node or vascular uptake, then we get a tissue biopsy with TB and fungal tests. If there is vascular uptake, it could be large vessel vasculitis, and then we investigate for that. What are the common causes of failed workup and missed diagnosis, which later we have found out the cause, but in my workup I have missed it, but the patient came back, went somewhere else and got diagnosed. Intravascular lymphoma, and 2-3 patients who were diagnosed with intravascular lymphoma where I missed during my workup, later diagnosed elsewhere, or they died because of late identification and late onset of treatment. Very difficult to diagnose in early phase. That is why I was talking about the new screening test which was there. Low-grade lymphomas, the histopathologist or the oncopathologist, it's very difficult for them to say that yes, this is a lymphoma or this grade. So again, the treatment and the diagnosis gets delayed. And also something as simple as prostatitis also has been missed in my clinical practice, and then they come back and later we have identified this is the cause. So that's in short a bit about my personal practice. And to summarize, even in 2025, FEO remains a challenge, even with all the diagnostics available, PET-CT, next generation sequencing, PCR, still it's a challenge. 20% is undiagnosed. Geography, travel, and exposure are important in history, like unpasteurized milk and exposure to animals for brucella, travel to malaria endemic regions for me in terms of malaria. Geography, again, whether leptospirosis or scrub typhus is endemic. History and physical examination is expected to give you potential diagnostic clues. Plus, please remember that heart murmurs, lung signs, and weight loss were only most relevant diagnostic clues. Most of the other diagnostic clues were misleadings. If we have a diagnostic clue, we can do target testing. If there is no diagnostic clue, then as per the new review protocol, the 2024, we go for an early PET-CT. On PET-CT, if you think tissue diagnosis is required, please go ahead and get that invasive tissue, especially for TB. And empiric treatment is now limited to very, very few conditions only. So that comes to the close of my presentation, and I stop here and I'll take questions if there are any.
Thank you so much, sir, for the knowledgeable session. Now, if you have any questions, please do post in the chat box. So we have some questions. Shobhna ma'am is also there. So we can take up with some of the questions which are posted in the chat box. So what the full form of CCI?
That's Charlson Comorbidity Index, CCI.
Okay, sir. Thank
Charlson
you.
Comorbidity, it basically looks at comorbidities and the organ involvement, and higher the score, more sicker the patient is.
Okay, thank you, sir. Then we have fever in toddler, viral or malaria can be diagnosed by which test? Ma'am, you are not audible.
Am I
Yeah.
audible? Yeah. So
Yes, ma'am.
yeah. So when we talk about fever in toddler, as I told you, we need to look for the focus. If it is we are suspecting a malaria, then definitely we go for the CBC along with the peripheral smear to see for the malarial parasite, and there is a malarial antigen test available to look for it. And other thing was viral. For viral, it needs to be seen whether it is a non-specific viral symptoms like the upper respiratory tract infection, then no specific test. It is only the symptomatic treatment. However, for other viral infections like dengue, we have the dengue NS1 antigen or the serology if the fever is more than 5 days. Over.
Okay, ma'am. What is the dosage of paracetamol
Yeah.
infusion?
That I have actually answered in the chat box also. That actually in children, we do not prefer to give IV paracetamol infusion. In most of the cases, we try for hydrotherapy, or in smaller children, we look for rectal suppositories are available, or the paracetamol oral suspensions. So IV infusions we do not recommend in children.
Role of mefenamic acid when it should be given?
See, mefenamic acid is no doubt an anti-inflammatory and antipyretic, but for safety wise, as I have told before, that generally we always asked and put, paracetamol as the first line. And paracetamol, the frequency can be increased. Most of the time, see why the fever does not respond to paracetamol is the fact that it is not given in adequate amounts. So you need to give in the adequate dosage. And do not wait for fever to rise very much. If you see that the fever is crossing 100, the child is becoming, sensing that the other symptoms are coming, please give paracetamol in adequate dosage and in higher grade fever and start hydrotherapy. And you can always repeat in 4 to 6 hourly. So as such, we do not prescribe for mefenamic acid in most of the cases.
Okay. There's one more question, ma'am. Doxycycline is recommended at what age?
See, doxycycline is an antibiotic. So it needs to depend, it depends on for which you want to give. For antibiotics, definitely doxy we do not give in the newborn age. That's for definite, especially in young infant. But for even in the higher, we do not prescribe antibiotics, as a blind hope. There need to be focus. So for the upper respiratory tract infection, we recommend amoxicillin. And for the fever like typhoid and urinary tract infection, cephalosporins are the drug of choice. The third generation cephalosporin like cefoxiam. So doxycycline, generally speaking, is being not given very commonly in children until and unless there is some culture report which is showing the specificity or there is some genital infection. So as such, it is not very a commonly used drug for infants and young children.
Hello, can I just
Yeah, please you can comment, Dr. No, might be for PO. Yeah, please you can come.
So from the fever of prolonged durations, the scrub typhus in Indian setting, especially in many South Indian states, it remains common. So the Indian Association of Pediatrics have cleared the use of doxycycline up to 7 days for even from the in the pediatric age, not in the infant or the neonatal group, but for the pediatric group, the Indian Association of Pediatrics guidelines and the data also from the Western world, both Indian IABS data doxycycline for pediatrics, especially because the best drug for the rickettsial diseases, even in children, was doxy.
So as a second line, once the fever is not responding and your enteric fever has been ruled out.
Correct. Because it is covered basically only for rickettsial disease, and now this last 2 years also for mycoplasma, because the macrolide resistance to mycoplasma has gone up. So that's the second indication for doxy.
Yeah, so that indication, like Dr. Anup has told, is very important when the fever is more than 7 days and not responding to the usual antibiotics, and you are suspecting, other fever causes like rickettsial and scrub typhus. So, as I said, the specific causes they need to be taken care of and not as started on a lower level.
Okay. And there's one more question: indications of prescribing antibiotics in 3 to 4 days fever.
Okay. So see, whenever we are suspecting, it depends again, as I outlined in my presentation. Generally, in less than 3 days, we do not prescribe until if it is a newborn or a young infant coming with signs, danger signs of possible serious bacterial infection, which I have been outlined. Then definitely after initial stabilization, we do give the first dose before the referral and sending the investigation. Once the investigations are sent, the results keep, coming, and you see that the blood culture is normal. It looks like to be viral. Then the antibiotics which have been started can be stopped. So the treatment should be tailored. This is about the inpatient admission I'm talking about. For a OPD patient or patient who is coming on a stable patient who is just coming for a fever of mild grade 3 to 4 days with a focus of infection like cough, coryza, do not start antibiotic. It could be a simple viral coryza illness coming with cold and cough, which will be settled down in next 2 to 3 days. And the child is not toxic, child is stable, eating well, mild flu-like symptoms. Please wait. So it depends on the focus and the presentation of the child. Always remember to give the antipyretics and the fluid therapy. The hydration has to be maintained. The child should keep on taking the oral fluids, and then you need to see.
Ma'am, there's a last question. Should we admit all these sick, irritable infants?
See, sick, irritable means irritable, sick infants, yes. Infants, again, as I told you, they are a high risk category. So they need admission, and basically they need evaluation and admission. So sickness needs to be defined. If it is a fever, there are chest retractions, or the child is not eating, then the child is called sick. Okay. Definitely it needs investigation, and the baseline investigations need to be sent. So at least they need to be evaluated by a specialist or a trained doctor, and then it needs to be decided further. So they should not be sent without, thorough examination.
Do multivitamin syrups play a role in children with fever or to improve their appetite?
Uh, See, multivitamin generally in fever, as such, also the child have a less appetite, So we do not recommend giving, additional syrup during the fever per se. We need to understand that while the child is sick, we need to give because in children, the giving medicines is not that easy. So we need to be very specific and tell the parents which medicine needs to be given very specifically. So I would request to limit the number of medicines to the essential one. Like if antibiotic is essential, tell the parent that this is essential. Child is vomiting, antiemetic is essential. So do not add in multiple multivitamins or iron syrup when the child is sick. Let the child sickness settle down. When the child comes for follow up after a week or two, then only you should give the supplements. Until unless the child is admitted and there are other conditions. This is I'm talking about the general fever child coming to you in the OPD.
Thank you, ma'am, for addressing all the queries. And thank you, Anup sir, for the insightful session.
Thank you.
Thank you, all the participants. The post-test link has been posted in the chat box. Also, we have posted the feedback link. Your feedback matters a lot to us for our improvement. This whole session can be, revisited on our YouTube channel. This session will be uploaded after 2 to 3 days on our YouTube channel, and you can revisit all the sessions. Till date, we have completed 27 sessions. Our next session is on 15th March, and the session is on approach to management of poisoning and management of common emergencies. The session will start at 3:30 on 15th March 2025. Hope to see you there on 15th March. And thank you for your patience listening.
Thank you, everyone. Thank you.
Thank you, ma'am. Dear participants, please submit post-test because pre-test and post-test are required to, for us to analyze and send you the certificates. Till now, we have received only 48 responses. Please, please, please submit post-test. The link is in the chat box. Please submit the post-test questionnaire. posters link, feedback link, and YouTube link has been posted in the chat box. Please share the feedback and also please complete your posters. So far, we have received only 97 posters responses. Please submit your posters responses. Please submit the post-test responses. Thank you, everyone. See you on 15th March. Thank you.